Assalamu alaikum. The short clinical day. First scenario, Mr. Adam, 55 years old, came with a complaint of abdominal pain. Please examine his abdomen. Here you
Okay, hello there.
Oh, hello.
I am Dr. Abdul Hafiz, one of the candidates to exam today. I want to confirm that I'm talking to Mr. Adam, and you are
Yes.
55 years old. Okay. So, Mr. Adam, I would like to examine you. So, during my examination, if you feel any pain or discomfort, please let me know. Okay. Okay. I will take 2 steps to the side of the bed, and I will make general inspection. Any abnormality?
No surrounding clues.
Okay. So then I will examine the hands for any clubbing, any conychia, any conychia.
Negative.
Any palmarity. Okay.
Negative.
I will check for fine tremors. I will ask the patient to extend his arms in front of him. Any fine tremors?
No tremors.
Okay. I will ask the patient to cock back his wrist, and I will examine for any flapping tremors.
No flapping tremor.
Okay. Then I will examine the pulse. The pulse.
The pulse is regular, 80 beats per minute with good volume.
Okay. Okay. So, and then I will examine the arms for any AV fistula.
No fistulas.
Okay. I will examine the eyes for any pallor, any jaundice.
No pallor, no jaundice.
Okay. I will examine the mouth.
4.
Any cyanosis, any pigmentation, any angular stomatitis.
No, none of that.
Okay. I will examine the parotid also. Any parotid enlargement.
No parotid enlargement.
Okay. I will examine the jugular venous pulse, the neck for jugular venous pulse.
Normal.
While the patient in the 45-degree
It's
position.
normal. It's not raised.
Okay.
It's not raised, so it's normal.
Okay. So after that, I will make inspection, near inspection to the chest and abdomen. I will inspect for any spider nevi, any gynecomastia, and I will take permission to palpate for gynecomastia. Any
no spider
dilated
nevi,
veins.
no dilated veins, no evidence of gynecomastia.
Okay. Any the shape of abdomen.
It looks okay. It's just like a middle-aged man with a bit of central opacity, not significant but very mild.
Okay. After that, I will make superficial palpation in the 9 quadrant. And while I looking for the face of the patient, any tenderness or masses?
No tenderness. No masses on superficial palpation.
Okay. After that, I will start deep palpation. First, I will do for deep palpation for the liver. Any hepatomegaly.
So the liver is palpable, 6 centimeters underneath the right costal ridge. What else you'd like to know?
Okay. And after that, I will do percussion to the liver also, and I will determine the liver span.
Liver span 18 centimeters.
Okay. And after that, I will do deep palpation for a spleen, splenomegaly.
No evidence of splenomegaly.
After that, also I will do percussion for spleen.
Percussion is normal.
Okay. I will do palpation for kidney by palatable, any palatable kidney.
Kidneys are not palatable.
Okay. After that, I will do percussion for any shifting dullness.
No
Any
shifting
ascites.
dullness.
Okay. After that, I will do auscultation.
1 minute left.
Auscultation for
For
bowel
any
sounds.
venous hum, any Berwi,
No pro-wee.
any
Bowel sounds
testing.
normal.
Okay. After I do that, I will ask the patient to sit up, and I will examine the lymph nodes.
No lymphadenopathy.
After that, I will examine the back, inspect the back.
No scars in the back.
Okay, I will auscultate the base of the lungs.
No crypts. Normal examination.
After that, I will check for sacral edema
No
and
sacral edema.
lower limb edema.
No leg edema.
Okay, I finished my examination. Thank you. I will cover the patient.
Okay, time is up. Examiner question.
Could you please present the findings?
Okay, by examining of this patient, he is comfortable in 45 degree, and his
What
pulse
is your diagnosis?
It is hepatomegaly for differential diagnosis. For differential.
Okay. Don't feel scared. Just continue. I'm just trying to mimic the exam status. Just continue.
Sorry?
I'm just trying to mimic the examiner. Just continue. Just continue your presentation. Tell me what's wrong. What findings? What make you think that it is hepatomegaly, etc.?
Yes, by examination, I find that there's hepatomegaly. It's 6 centimeter below the costal margin, and the liver span is 18. Okay. There is no stigmata of chronic heart disease, chronic liver disease, and there is no lower limb edema, sorry, just the positive finding here, it is the hepatomegaly.
What's your differential diagnosis?
My differential diagnosis, it is chronic liver disease, but again, that there is no stigmata of the chronic liver disease. Hepatitis, alcoholic hepatitis or hepatitis C or B. It is also was consistent with the abdominal pain, the presentation of the patient. Okay. Also, I can put also congestive heart failure, and I will put also lymphoproliferative disorder can cause hepatomegaly. Okay.
Anything else?
Maybe also infiltrative diseases like amyloidosis.
Okay. Anything else?
No.
How would you investigate this patient?
Firstly, I will do basic investigations into the form of a complete blood count, renal function test, and liver function test, electrolytes and inflammatory markers. I will also search for the confirm the hepatomegaly by ultrasound, abdominal ultrasound. I will search for the underlying cause by doing hepatitis screen. Okay. I will do also autoimmune profile. So
Why do you need to do autoimmune profile here?
for any autoimmune hepatitis or
Mm-hmm.
primary biliary sclerosis, primary biliary cirrhosis, or primary sclerosing cholangitis.
Are you aware of any particular markers we are looking at here?
Yes, anti LKM and anti-smooth muscle antibodies. Yes.
Okay, and how would you treat this patient? I think 4 minutes are already finished, but how would you treat this patient?
Okay, I will, according to the underlying cause, if this patient have hepatitis, so I will give him hepatitis C or hepatitis B. I will give him the antiviral medications. If it is autoimmune cause, or if it is alcoholic hepatitis, I will stop alcohol. And I will, if it is autoimmune hepatitis, I will give corticosteroids or immunosuppressive medications. Okay, and also we will also some non-pharmacological medications, non-pharmacological like vaccinations and regular follow-up. And the treatment of complications if happened, if it is for chronic liver disease like ascites or encephalopathy.
What other complications for chronic liver disease?
Portal hypertension also. Coagulopathy. Ascites also. Ascites and portal hypertension and coagulopathy, encephalopathy.
Well done.
Okay.
Okay, your comment, Dr. Ines, please. The skills also, based on the skills.
Oh. Let me just have a look at the skills section. Okay. Physical examination. You were able to identify a hepatomegaly. Not all hepatomegaly has peripheral stigmata of chronic liver disease. At the start, you missed checking for the lymphadenopathy, but you've done it at the end. It's very important to check for lymphadenopathy, particularly if you're dealing with hepatosplenomegaly or splenomegaly. When you appreciated the liver, you did appreciate that it is centimeters, but you did not comment on the texture of the liver. You did not comment if it is tender or not. You did not comment if there is any probe on the liver or not. You were able to identify a liver span, which was good. You examined the liver on the supine position, but when you do the shifting dullness, always examine for the spleen and for another time, particularly small spleens will be more obvious on the lateral position. When presenting the case, a lot of times there are two ways of examiners in the exam. One of them will tell you what is your positive findings, and the other one will tell you what is your diagnosis. Either way, if you've been asked what is your diagnosis, it's not just about it is hepatomegaly or this is a splenomegaly. It's about, I believe this patient has hepatomegaly. This is evident by 1, 2, 3, 4, 5. Or what is your positive finding? My positive finding 1, 2, 3, 4, 4, 5. Putting all of that together, this is a hepatomegaly or splenomegaly or hepatosplenomegaly. For this gentleman, he has not had any peripheral stigmata of liver disease. He has had no clubbing, no leukonychia, no jaundice, no abdominal distension, no spider nevi, no gynecomastia, You've had a look to the hair and there is no abnormality in the hair distribution, etc. And no xanthelasma, for example. So all of that tells you that it's not really chronic liver disease. Now we really want to think why this patient has a big liver if it's not a chronic liver disease, okay? When presenting the case, I would have presented it as, this patient has features of hepatomegaly. This is evident by an enlarged liver in the right upper quadrant. It was 6 centimeters underneath the right costal margin. It was smooth to feel, non-tender, with no proi over it. The patient was evolemic. I did not appreciate any signs of chronic liver disease and just mention few which are negative. The patient, for example, has had no spider nevi, he has had no clubbing, no leukonychia, and he has had no gynecomastia, for example, if you want to mention it. And the patient has had no features of hepatic encephalopathy, evident by the patient has no asterixis, and his cognition to me seems to be normal. And the patient has had no signs of portal hypertension, evident by no ascites and no splenomegaly. So putting all of that together, I believe this patient has isolated hepatomegaly. Full stop. Second question would be, what are the causes of hepatomegaly? I'm trying to find my summary actually for hepatomegaly. I'm unable to find it, but I'll just say whatever I can remember from it. I usually divide them into congestive causes, infective causes, inflammatory causes, infiltrative causes, and there's one more, neoplastic or malignancy, and the third one, miscellaneous and other kind of causes. Congestive causes could be due to congestive heart failure, constrictive pericarditis, Budd-Chiari syndrome. And in these conditions, you would expect the liver to be tender because it is congested, which is not the case here, but this is one of the top categories that you need to mention. The second differential is metabolic causes for me. And on the top of metabolic causes are MASLD or metabolic syndrome of steatotic liver disease. You would be able to pick other clues for the patients like acanthosis nigricans or what we call it, xanthelasmas or central opacity or any evidence that might tell you high body mass index, anything that can tell you that this is a metabolic syndrome. Other causes, other metabolic causes are glycogen storage disease. It's glycogen storage disease. You can put it under metabolic or you can put it under infiltrative or storage disease or storage disorder. So we finished with congestive causes. We finished metabolic causes. Now we speak about inflammatory causes. And inflammatory causes could be any cause of inflammation. It's either due to alcoholic hepatitis or due to viral hepatitis or due to alcohol or due to autoimmune hepatitis. And as soon as you remember autoimmune, you remember the biliary causes that are due to autoimmune diseases like primary biliary sclerosis or primary biliary cholangitis, these two. And the fourth category is, so we finished congestive, we finished metabolic, we finished inflammatory causes. Now infiltrative causes. Infiltrative causes could be due to amyloidosis, it could be due to hemochromatosis, it could be due to Wilson's disease, it could be due to alpha-1 antitrypsin deficiency. And the fourth one is neoplastic or malignancy, which could be primary hepatocellular carcinoma or secondary metastasis to the liver, or it could be hematological malignancy. And in these cases, you're more likely to expect hepatosplenomegaly and a bit of lymphadenopathy. And the fourth one and the last one is miscellaneous causes like cystic disease, cystic liver disease as part of polycystic kidney disease or as isolated cyst in the liver. And actually, I forgot one section, which is infective causes, which you could put infective. You can put viral hepatitis under infective causes, but I usually put it under inflammatory causes because it causes inflammatory hepatitis. But you could put here viral hepatitis. You could put pyogenic abscess in the liver, amoebic abscess in the liver, or hydatid cyst. So this patient could have a cyst, which isolated cyst, a normal cyst, simple cyst they call it, or it could be an abscess, or it could be hydatid cyst. Okay, so this is the differential. Sorry, it's not very organized, but I cannot find my summary for it. But these are the main kind of differential diagnosis. In terms of what are you looking in the bloods? Very good. You mentioned most things, but try to say what is the rationale behind it. So I'd like to do a full blood count. I'm expecting to, I'll be looking for any signs of anemia, or I'll be looking for any signs of thrombocytopenia, which is important in liver disease. Whenever you touch a liver case, always ask for a clotting and INR. And apart from the routine ones that you mentioned, ask for a ferritin, transferrin for hemochromatosis, ask for alpha-1 antitrypsin for alpha-1 antitrypsin deficiency, ask for ceruloplasmin for Wilson's disease, and of course, ask for the hepatitis screen. And when you think about malignancies, ask for alpha-fetoprotein if related, okay? And very good, you mentioned scans. You start with an ultrasound abdomen. If any concerns about congestive causes, you do an ultrasound Doppler. And if any concerns about scarring or cirrhosis, you do a fibroscan. So when the liver is fibrotic, it's usually small in size, but you never know. Maybe this part of the liver is big and the other part is fibrotic. So if you're concerned about chronic liver disease, get a fibroscan. And I've learned this from actually a teacher when I've done my PLAB too. Whenever you've been asked about a management plan, you have a golden moment. Always, always, always see the outline of the management. I would like to manage this patient under the multidisciplinary team approach as per the underlying cause, full stop. Otherwise, you will keep talking about what could be the cause, because abdominal pain is very general presentation, and it could be like nothing at the end. It could be not liver related. And by the time you explain all differential diagnosis for hepatomegaly and investigations, you would have barely 30 seconds to mention what is your management plan. So just have a golden moment of saying, I'd like to manage the patient under the multidisciplinary team approach, and that would involve a hepatic specialist, a hepatic nurse, and other like nutritionists, dietitians, according to the underlying cause. I hope that makes sense.
Yeah, perfect.
Yes.
Nice talk, really. Thank you, Dr. Inas. So back to the skills. What do you think about the physical examination? The steps was perfect. Anything missed?
No, I think it was systematic.
Okay.
Yeah, I would give him satisfactory. Yeah.
So this is the physical. Identify the sign as well. He could appreciate the signs. I believe you can say the span with the fingers better than mention it in the centimeter. So
Yeah.
I can
Okay.
feel it 2 centimeter below the costal margin. So approximately, for example, 8 fingers or 6 fingers, whatever the size.
Okay.
Then the clinical, the differential diagnosis. He was confused a little bit, but he corrected the differential later on. He remembers some of the points, but let me organize it based on the area you are or the zone you are having the exam. For you, Dr. Ines, you have to put the alcoholic on the top. For us as Middle East centers or overseas, we will put the infective cause in the top. So
Okay.
you have to organize to put the order according to the zone or the area you are examining.
Okay.
Otherwise, as you said, put the category as a differential. Don't say hepatitis C, hepatitis B, HIV. No, you can say it. He will know that you are organized. It's infective cause, as you said, the alcoholic, non-alcoholic. Almost whenever you mention the alcoholic, say the non-alcoholic. So alcoholic and non-alcoholic, two differential and major differential, by the way. So the non-alcoholic also one of the important and is very common. Most of the normal people, because of the obesity, they have the fatty liver and they have the non-alcoholic liver disease. So you can say it as always linked to the alcoholic. So alcoholic and non-alcoholic, infective, infiltrative, neoplastic or malignancy. You put 5 of them, which is very important and very common. You will add to them, Dr. Hani, the autoimmune hepatitis or the biliary hepatitis, biliary cirrhosis or the primary sclerosing. Okay, you finish the autoimmune. The last, as I mentioned in the chat book, the drug like methotrexate, some drug use or hepatotoxic medication. So methotrexate, you can add also the paracetamol. That's it. You can add also storage disease as different, or you can put it as metabolic. The infiltrative, of course, if he asks you, give me example of this, you can give a lot of examples. Infiltrative, hemochromatosis, amyloidosis, and Wilson. You can also put the storage disease if you can remember. Okay, so always Dr. Hani give it not as 1, 2, 3, as a category. Infective causes there. I know also infiltrative causes, about neoplastic causes, about alcoholic, non-alcoholic. Then if he want to know more from you, he will ask you, give me example of this, give me example of that. What do you know about this? What do you know about that? Then, yeah, so the differential, I can't say it's marked down because of the disorganized way, but Dr. Han, I think he will not forget it again. Let's go to the next skill, clinical judgment.
I think satisfactory as well.
Okay, the welfare also maintained because he thanked the patient,
Yeah.
he prepared, he
Yeah,
did
yeah,
everything.
yeah.
So only 2 marks for
And
the
honestly,
research.
they look for these kind of things. They look if you covered the patient afterwards. They will look if you thanked the patient afterwards. So
Perfect.
all
Yes.
of that add points.
Yes, it makes sense. All of them make sense. Thank you, Dr. Ines. I will add just for the presentation, Dr. Hani. Always, not only you, everyone, present the positive finding. If you want to present the negative signs, don't say, I couldn't find lower limb edema. This is a single sign which doesn't make sense to mention it. So what I will say, no signs of volume overload, no signs of chronic, or as Dr. Ina said, no signs of decompensated liver failure. He will tell you what you know about the decompensated liver failure. You can say a coma, encephalopathy, or the tremors, the spider nevi. Sorry, this is not. This is for the chronic liver disease. So the signs of
Jaundice,
decompensated liver,
splenomegaly,
jaundice, splenomegaly,
splenomegaly,
ascites.
ascites,
Yes,
like
and I think the tremor, right? Ascites,
flabbing
which
tremor.
tremor, ascites, encephalopathy, and the jaundice. Yes. Okay. So say it as a collective signs, not as separate or single signs. So I couldn't appreciate any signs of decompensated liver failure here, or I couldn't appreciate also signs of ED, volume overload, or heart failure as well. You can say it. One of the if there is suspicion of drug or immunosuppressant medication, you can also say, I couldn't find signs of immunosuppressant toxicity or toxic or high dose of immunosuppressant medication. No need to mention, as I said, one by one. He will know that you meant this. You meant this because you are doing also the examination. Whenever you open the mouth, you are checking for the gum hypertrophy. Means that you are checking for the side effect of the immunosuppressant medication. Okay. The tremor also one of the positive finding. I think I don't know if you mentioned it or no, or it was negative. The fine tremors, flapping tremors, sorry, flapping tremors. Was it there?
He did ask for it, and it was negative.
Also was negative. Okay. So this is the way how to present. As I said, positive finding only. Then if you couldn't find anything else, you can say I couldn't appreciate signs of, for example, chronic liver disease, decompensated liver failure, or volume overload. If you are in immunosuppressed or drug, or sorry, the transplanted organ, no signs of immunosuppressant toxicity. And if you have kidney or renal case, you have to mention the current mode of renal replacement therapy, the previous mode of renal replacement therapy, and the underlying cause of the renal replacement of the kidney disease. The last thing, as Dr. Ines said, whenever you are managing, start by multidisciplinary team approach and treat the underlying cause. You cannot control, and you don't know how to diagnose this patient from first look. You cannot do it. Never ever say, I will give this patient hepatitis B medication, cirrhosis medication. How do you know? You didn't do the other scan, you didn't confirm the cirrhosis. So what can I say? Treat the underlying cause. according to the infection, I will treat the infection. Alcohol, stop the alcohol, but don't mention one by one. So if he asks you how to treat this, you can say, I will do this. How to treat that, I will do that. Okay? Any question,
Sorry,
Dr.
can I
Hani?
ask?
Yeah, sure.
I thought we missed mentioning congestive causes and vascular causes as a
No,
cause
you
of
mentioned
hepatitis.
it. You mentioned the bad carry, you mentioned the congestive heart failure. Yeah, I didn't, yes. I missed the congestive cause. Yes, you're right. So let's talk about the congestive liver or hepatitis due to congestive heart failure. What do you think the clue of this condition while examining the patient? Sorry?
Tender liver.
Raised
Perfect.
tender liver
Both of
and
them. Yeah,
raised
you
gender.
mentioned, both of them mention it. Raised GVP, so we will have the signs of heart failure, as well as Dr. Inas also mentioned, tender liver. And by the way, this is one of the questions. When you will have tender liver? One of
I
them,
think is a
congestive liver
differential
failure.
of
Yeah, okay.
if he asked specifically about the tender hepatomegaly, it will be congestive heart failure, as you say,
Okay,
and
perfect.
infectious causes,
Perfect. Yeah.
and
In particular, the acute cause, like
alcoholic,
hepatitis A, hepatitis A.
hepatocellular also, hepatocellular carcinoma.
The carcinoma itself, I don't think unless there is complication, okay, like thrombosis or rupture or bleeding.
Stretch of capsule, liver capsule.
Yeah, could be by the enlarged liver. Yes, yes, you're right. Okay.
Mm.
What else in tender?
Bad carry also.
Bad carry, perfect. Yes, painful. What else?
Alcoholic hepatitis.
Alcoholic, it wouldn't be unless there's also complication or stretch of the capsule, also the enlargement, massive enlargement.
I thought
What I
anything
want
that
to
would
say,
cause hepatitis would cause tender.
abscess. Yeah, this is what I want to say. The abscess, liver abscess, or
Congestive heart failure also. Congestive
yeah,
heart
we
failure.
mentioned it on the top of
Oh,
them.
okay,
Congestive
okay.
heart failure.
Yes,
This
yes,
is the
yes,
most important to mention in the tender liver, congestive heart failure. Then you can talk about the infectious cause or the infective cause, acute hepatitis A, or other complication. The cyst itself, you can say also cyst, rupture cyst, because of also polycystic kidney or hydatid cyst. Okay, the liver abscess as infectious cause, as infection cause. Okay, inflammatory one, it's not that much painful, but it can also be due to the active inflammation. Okay.
Sorry for the question.
Yes, Dr. Harris.
I was mildly panicked. Why?
Yeah.
Because my case in Jordan Center, it was hepatomegaly, but I missed the case actually.
Yeah.
So I remember what happened, and actually
Yeah.
I was shocked. Why? What happened exactly when I examined the patient? And
Mental block.
not mental block.
Okay.
During palpation of the liver, the patient make his abdomen rigid.
Okay.
Actually, I don't know what happened. I said him, please try to be relaxed. To the Arabic patient, Jordan patient, I said him, become relaxed. I don't know what happened for him. Maybe I was not gentle in palpation, but his abdomen become rigid. I can't palpate anything.
You try
And
to flex his knees?
no, I
No.
forget to do that, and I forget to
Exactly. Yes.
tell the examiner the patient is not
Yeah.
cooperative or like that.
Hmm.
Because so when I don't know what I do. The
Oh,
patient is making his abdomen rigid.
yes.
I can't palpate the liver. I can't palpate spleen. I do the technique anyway, but I don't have any. The only positive finding in this case is was hepatomegaly.
Okay.
I lost the case
Yeah.
because of this.
So, what about the feedback? Did they put anything related to the welfare? Or
Yes, I can. I will try to share the feedback.
yeah, was
The
it
feedback.
related the welfare or
No,
the
at all.
physical finds? Physical sign.
No, they unsatisfactory physical examination, unsatisfactory
Oh my God.
finding, unsatisfactory judgment.
Oh my
because
God.
because I don't catch the diagnosis actually.
Okay, yeah. So it's
Uh,
linked skills, as I said before.
yes,
It's
yes,
linked
yes.
skills. Whenever you didn't catch the finding, if you didn't pick up the finding, you will not have the clinical judgment properly. You will not have the good differential diagnosis, and the welfare only will be positive or satisfactory. You might have the marks only for the welfare,
Can I
right?
suggest
Yes.
something here?
Yeah, sure.
So I'm not good either with picking hepatomegaly, to be honest. And my center is the center that I'm going to now has a lot of hepatomegaly, but I've learned a technique called scratch test. It is, if you Google it, it's about putting your stethoscope under the xiphisternum and try to elicit a sign. And in research, they say it is as sensitive as an ultrasound in picking organomegalies, because I find it hard to explain it here. But if you Googled it, it's called scratch test, and it is used for splenomegaly and hepatomegaly, and it's all about transmitting the sound through a solid organ. So instead of feeling that sound up until the ridge of the costal ridge, you would feel it between the umbilicus and the costal margin. And that tells you that there is a mass here and it's likely hepatomegaly, particularly with patients who have massive abdomens, they have ascites, they have SPP, where you cannot really put much palpation effort because the patient will be in pain.
Yes, it's applicable, but I don't think it can be done in PACES exam. I don't know if anyone
I've been taught
tried or
this
experienced
in a
it.
PACES course.
Okay,
Yeah,
so
I've been taught this in a PACES course because he was a cardiologist in London, and he said a
okay,
lot of times you find it very, very hard. And apparently, he's as a cardiologist sometimes use
okay.
it for his patient, and this is where he shared the word about it. But
It's a smart way. It's a very smart one, and it's advanced one. You have to train on it because it will
exactly.
take some time to do. You put the stethoscope, you will sketch, and try to based on maybe the time of other exam steps. So I
I
don't
think
know.
use it if you got stuck, if it's not a
Yeah,
renal case, not obvious
yeah,
of any signs, and you
yes,
have
you're right.
1 minute left. What are you gonna do? You need a positive
Yeah,
finding
exactly.
to.
Yeah. Yeah, if you didn't find anything while doing the superficial or deep palpation, and you are in doubt, is it hepato, is it not hepatomegaly, you can do it if you are stuck. Anyway, if we can recollect and recap the cause and the cases and paces in the abdomen, you have either one of the three related to the liver, three cases. The liver, I'm not talking about the kidney. Of course, the kidney we'll talk about either a fistula, either channeled line, tunneled denial, tunneled catheter, and the patient in the stage, or the adult polycystic kidney disease, or the renal transplant. This is regarding the renal, okay? Regarding the liver and spleen. So either you will have isolated splenomegaly, or hepatosplenomegaly, or cirrhotic liver with splenomegaly. So again, either you will have hepatomegaly or hepatosplenomegaly, or isolated splenomegaly with shrunken liver or cirrhotic liver. This is these are the possible cases in PACES. You will be lucky to have the hemolytic case, hemolytic anemia case. So you will have possibly you will have the jaundice, anemia, and either splenomegaly or hepatosplenomegaly. But at least you catch the signs in the face, which is enlarged maxilla and the jaundice in the eye. Okay, frontal bossing. You can, from spot diagnosis, I said, as you said, from the spot diagnosis from the face, you can know this is a chronic hemolytic anemia patient. So you can guess, supposed to have hepato and splenomegaly. You'll be lucky if you have such case. Otherwise, as Dr. Hani said, it's sometimes you have some difficulty to palpate the liver. However, you have to be trained also on that. The spleen, you have to palpate the spleen. This is easier than the liver. Okay, so you can feel the spleen. Even in one patient, one day I felt the notch, splenic notch. if the patient is thin, you can feel the notch itself. So you can try to do it. And whenever you are explaining or mentioning the finding, try to say 3 description about the hepatic or the liver. Like as Dr. Ines said, is it tender? Is it firm? Consistency? Is it what else? The consistency and the tenderness and the movement. Yes, the movement with the diaphragm or with the spiration. Okay, you can say at least like you are describing it. It's not important to find all of them, but you can guess them. Okay, so the liver moves with this respiration, and also either tender or no according to the patient's face. And the firm supposed to be the consistency supposed to be firm if you have a hepatic or hepatomegaly. The same as the spleen. Okay, and the difference between these organs and the kidney is not moved with the respiration. I think we collected and gathered most of the abdomen case. Anyone has question or comment? Dr. Hani and Dr. Ines? Yes.
Assalamu
Yes.
alaikum.
Walaikum
Thank you
salam.
very
Yes.
much for this nice case and interpretation from Dr. Inas for this case. I do agree with you, Dr. Basim, regarding the presentation of the case. It's very important to start by positive things. I saw one examiner in a video. He mentioned that if we start by negative, this is more irritating to them. So just positive finding and important negative at the end. This is very important. I saw this examiner mention like this. Another things when in the differential diagnosis like this hepatomegaly, nowadays and non-alcoholic liver disease as an emerge as a top in developed and non-developing country. So it is very important to prioritize our differential also because this is make them to give us more things. And also like this hepatomegaly, when we're screening the patient, it's important to show them we are screening the skin of the patient, because it is very important to looking for any things in the skins like tattooing and tanning or anything indicate and to have around to the patient also for body mass index. It's very important. Thank you very much. It's very nice case as usual.
Perfect. Thank you, Doctor. I think Dr. Mohira, right?
Yes, yes.
Yeah, perfect, Dr. Mohira.
Yeah, I agree.
You
Thank
mentioned,
you for the comment.
yeah, it's a nice comment. The last point, the skin usually have a lot of things, and you have to notify it to the examiner. I noticed tattoo, I noticed clubbing, I noticed standing, bronze skin if you have hemochromatosis. Okay, so it's important to notify the examiner about the skin or the finding in the general examination. The weight itself is very important to mention. I noticed this patient is overweight, for example. It makes sense to add it initially before presenting the patient. Because does it relate? Yes, it's related. Directly, yes. If you have, as Dr. Mahira said, if you have non-alcoholic, so the obesity here will be on the top of my differential, non-alcoholic liver disease. Of course, if I couldn't find other underlying pathology. Okay, and whenever let's add the last comment before moving to the next case. Whenever you have inherited condition like Wilson, like hemochromatosis, alpha-1 antitrypsin, don't forget to add to the team or to the screening genetic screening. Okay. Regarding the difficulty of Dr. Hani, whenever you have difficult to palpate the abdomen or the abdomen is tense or rigid, flex the knees. It's very important. Plus, of course, be sure that you put the patient in flat or supine position. If you don't put it or put the patient in this position, believe me, they will fail you whatever you do. Okay? By the way, the examiner or some examiners, the tough and toxic examiner, when you do the technique bad or you made up finding, they will fail you whatever you mention and whatever you do, whatever you explain, whatever you examine, because you irritated them. Okay, and you can't see these marks in toxic center. So, as Dr. Hani said, I think by his definition and by his mentioning to the examiner unsatisfactory, I think he got maybe 6 or 7 out of 20, and he can do it in the toxic centers. He will just give you and preserve the marks for the welfare. Otherwise, he will minus you in the all skills, which of
I
course.
just sent it I sent it my feedback about this case to you in the WhatsApp. You can check
Okay.
it, Dr. Basim.
Okay. Actually, some examiners are also having very bad handwriting. Even the comment, the feedback, you cannot read it
Oh,
to improve.
all all of them.
Right, yes. I saw a lot of feedbacks, and they are the same. I don't know why they are doing that. If you want me to improve something, write it clearly. How can I improve this skill without mentioning to me that I have defect in this skill, in this part? Okay, so give me a clear handwriting. I will try to improve it next exam. Or you will just waste my money. I will go the same exam or the next exam with the same defect and another examiner with the same handwriting and so on. Okay?
If you notice that, Dr. Basim, you can open the first paper. I send it to you. Just when they give me unsatisfactory in the identifying physical signs because I
And
miss
without any
hepatomegaly.
comments. Yes.
Yes, no. They writing missed hepatomegaly. Okay.
Yes.
And there was it is a scar. I don't know what is this scar actually for what. It is midline, but below the umbilicus and below the umbilicus. I don't know for what is scar. He asked me. I said there is a scar. He said for what this is scar. I don't know.
You can say.
I say maybe it is.
Okay,
It
what you
is.
say?
I said it is maybe for prostatectomy or urinary bladder
Okay.
operation or splenomegaly. When I said
Okay.
splenomegaly, he stared, staring.
Yeah, maybe some
He
words, by the way,
look.
some words you can say, whenever you say to the examiner, he might be more irritative and he will fail you more than he wanted before. Okay, so like you are irritating him more and more. What could be a scar in the abdomen for any
But
patient? I'm giving you general exam question. You have a patient in your clinic with a scar in his abdomen, small scar or big scar. The most common thing in all obese patient and most of our public people, what do you think? Because of the low exercise and because of big tummy, what is the most common scar, Dr. Hani, or anyone?
Whereabouts? Upper or lower abdomen?
Okay, let's say upper, lower, any area. I'm not specifying area, but it's very common one. It's not unrelated, but unrelated to the case itself, but could be indirectly related. Hypoalbuminemia, liver, chronic liver disease. Patient have weak muscles. So what could be the scar?
hernia?
Hernia, yes, hernia repair. Just if you mention it as a common one, yes, it could be. Why not? But prostatectomy, oh my God, it's something very rare to mention, and maybe also why it's upper, why in the suprapubic area, maybe down, maybe transurethral. Why do you assume it's prostatectomy? What I want to say, give something makes sense for them. So the hernia repair, you can imagine a lot of patients in every admission, he will have history of hernia repair with mesh, hernia repair with mesh, because of our, of course, food habit, and also large tummy, weak muscle, no exercise, the lifestyle itself. So you can have this as a finding, or if it's not related, if you mention the hernia repair as a common scar or a related or unrelated scar, he will accept it, right? I'm not talking about a
Yes.
specific scar, just scar for in the abdomen, which is not related to the case now at the time being or at meanwhile, but for general finding. Sometimes, by the way, you will find a scar and you have asked what could be this scar. You have an answer. better than saying something rare or you don't know, better say I don't know. I cannot remember now. I don't have explanation. But if you say something rare, of course he will be irritated more, and he will be also giving you mark down. Anyway,
when
yeah.
he write unsatisfactory for the identifying physical signs, he give unsatisfactory in the differential diagnosis and satisfactory in the clinical judgment, and write linked mark just in the comment.
Yeah, this is what I said. So it's linked skills, or linked skills mean you didn't catch the diagnosis. You didn't have good physical examination for him. Even if you do the physical examination properly, but for him, you didn't make sense for him, the examination step. You didn't, of course, give him the diagnosis as one of the differential diagnoses, and you didn't judge and give investigation related to the case because you didn't catch the diagnosis. This is the worst scenario in PACES exam, when you cannot catch the diagnosis and you just give an answer for an of course wrong answer because you didn't catch the diagnosis. So whatever you are saying, it's wrong. The differential will be wrong. The signs, of course, because you couldn't find the signs, it will be also unsatisfactory. At the end, you will get maybe 6 or 7 out of 20, which is the worst mark. Maybe, Wallahi, I read and I saw some feedbacks with only welfare, 4 out of 20. Imagine. Again, these things in the toxic centers. Okay.
And someone was 0 out of 20.
Oh my God! Even the welfare.
Yeah, I think
Why?
the doctor she was holding a piece of tissue with her hand. It was clean,
Oh.
but they commented on the hygiene, so this is why she lacked even the welfare. Bless her.
Oh my God! Yeah, you're right. White tissue in the exam, even if you are drying your sweat, still it's not a reason to hold the tissue. Anyway, hopefully you can do it next time, both of you. Any question or comment, Dr. Hani, apart from the comment we mentioned?
No, thank you.
Okay, before Dr. Asila, as usual, commented, which is more important to mention before hepatitis C virus or non-alcoholic fatty liver disease as a cause, regardless of body weight, because both are common in developed and developing country. Okay, let's put it as a center. For example, if you have exam in overseas, you want to mention the hepatitis. I said it before. So hepatitis C will be in the top. If you are in UK, the hepatitis B will be in the top. Regarding the non-alcoholic, it's not necessary to have obese patient, but the clue, if you have the obese patient, to put it. However, if you are in UK, alcoholic will be before all of them.
That
Okay.
has changed, Dr. Bassem, recently. Now it's not alcoholic. It's not actually. It's called MASL now. Metabolic syndrome with cystic liver disease is the most common
Okay.
cause.
Yeah,
But that's just a change in the last few weeks.
Okay, so they changed the term to
MASL, metabolic syndrome of steatotic liver disease, and it's now more common than alcoholic liver disease.
Yeah, again, it's for the lifestyle also.
Exactly.
Related to the lifestyle. Okay, but it's difficult now to mention it as alcoholic or non-alcoholic. Now you have to say alcoholic and the metabolic.
MASL.
Yeah, this.
Everyone knows MASL here.
Yeah, it's, but you cannot say it to the examiner. You cannot say measles as a term. You have to say it in full term.
Metabolic.
Avoid the abbreviation as much as you can.
Okay.
Okay, clear now, Dr. Asina? Alcoholic, it's difficult to mention it in our Middle East or our overseas centers. Okay? Yeah, it could be, but it's not common as the hepatitis, for example, or the measles. So put the alcoholic the third now. Okay, let's go to the next case, Dr. Inas. Your patient, Mr. Hassan, 60 years old, gentleman. He came for follow-up cardiovascular examination.
Okay.
Yes, here it is. Yes.
Hello. I'm Dr. Alalul. I'd like to examine your cardiovascular system today. And that would involve looking to your hands, your face, and examining your heart. Is that okay?
Okay.
Do you have any pain or discomfort?
No.
Okay, if I cause you any pain or discomfort, please let me know. I'll start by asking the patient to expose their chest. Ideally, they should be exposed from the waist upward. I'll look from the end of the bed, looking for any signs of shortness of breath or any signs of obvious cyanosis from the end of the bed, any obvious scars.
Yeah, from side of the bed, you mean?
From the end of the bed, any signs that I
Yes.
could appreciate. Is the patient short of breath?
And no, the patient is not in short breath.
Any scars that I could appreciate from the end of the bed?
You can't appreciate maybe from the side of the bed.
Okay, that's fine. Now I'll move into I'll look for any surrounding clues. Then I'll move into the hands. In the hands, I'll be looking for any clubbing, any any splinter hemorrhages, any osseous nodules, any Janeway lesions, any palmar erythema, and then I'll move into the pulse. I'll check the pulse, the rate, the character, and then I'll check for any radial delay, and I'll
Okay,
offer.
about just one by one. Okay,
Mhm.
about the hand inspection, no abnormality. Radial pulse, it is 80 beat per minute regular. What you want to know about the pulse other than that?
Good volume.
Yes.
Any radial delay?
No radial delay.
I'll offer a radiofemolar delay check, and I'd like at this point to ask for blood pressure, and then I'll move into the face. I'll just offer it.
You
the
need to check anything other than in the pulse?
anything of the pulse that I'd like to check. I'd like to check for a collapsing pulse as well.
Yes. Okay. Anything else?
Not on the top of my head.
Okay. Equality. Okay.
Okay,
Let's go.
a collapsing pulse,
okay.
negative or positive?
Negative.
Negative. Okay. I'll now move into the face. In the face, I'll be looking for any facial plethora, any congestion of the face, of the neck. I'll look for any jaundice, any signs of anemia, and then I'll look for any central cyanosis in the mouth.
Okay, no problem in the mouth.
And now I'll move into the neck. I will check for the JVP at 45 degrees.
Okay, no raised PVP.
Not raised JVP. Okay. Then I'll move into the chest. I'll examine closely for any scars. I'll ask the patient to have a look to the armpits. I'll look in the back if there is any scars.
There is a scar by inspection. There is this scar, midline sternum scar.
Midline sternum scar. Now I'd like to go to the legs, and I'd like to find if the patient has any harvesting scars.
Yes, there is harvesting scar.
Okay. I'd like to see if there is any click that I could hear from the end of the bed or from the side of the bed. Any metallic click.
Yes, there is metallic click. I shared just the harvesting scar, the photo. Okay.
Oh, sorry. Yeah, sorry. I'm not looking to the chat. Okay. I'd like to have a look to the hands, to the arms, sorry, to see if any signs of bruises or any suggestion that may tell that the patient is on anticoagulation.
No bruises.
No bruise. Okay. Then I'll start by palpating the apex beat. I'll try to find if it is in place or displaced. I'll try to identify the character of the apex beat, if it is hyperdynamic or what character of the apex is it.
Okay, the apex is located at 6 intercostal space, lateral to the midclavicular line, and thrusting in nature.
Thrusting. And did you say anterior axillary or what line? Is it anterior axillary or?
Lateral to the midclavicular line.
Okay, just lateral to the midclavicular line. Okay, and now I'd like to check if there is any right ventricular heave. I'd like to feel if any thrills all over the 4 valve areas.
No thrills, no parasynal heave.
Okay, now I'd like to listen in all valvular areas for S1, S2, and find if the metallic click coincides with the pulse or just after the pulse. And I'd like to appreciate if there is any murmurs and see if it is extenuated with inspiration or expiration. I'd like to have a listen to the axilla for any radiation and to the carotid for any radiation as well.
Okay, by auscultation, there is a clicky first heart sound and loud second heart sound.
It's loud second heart sound.
Yes, and the clicky first heart sound.
Okay, so sorry, the click, is it with the pulse or just after the pulse?
The first heart sound is clicky. And by timing, it is a first heart sound.
Okay, so there is a metallic click that coincides with S1, right?
Yes, that's right.
Okay, fantastic. Okay, any murmurs?
No murmurs.
No murmur. I'd like to quickly check for any basal crepitations, and I'd like to check for any pedal edema as well.
No, please, no clarification.
Thank you. I'd like to thank the patient and cover them, and that completes my examination.
Okay, thank you. Time is up. Question now.
Okay, can you present your finding?
So this patient has evidence of a well-healed mediastinotomy scar with a harvesting scar. On auscultating the chest, I did appreciate a metallic click that is coinciding with S1, and I appreciated the apex was displaced to the 6 intercostal space, just lateral to the midclavicular line. I did not appreciate any right ventricular heave or any thrills. The pulse was regular in nature with a rate of 80 beats per minute. Putting all of that together, my differential diagnosis for this patient would be a metallic valve replacement, likely a mitral valve replacement, and he has had a coronary artery bypass surgery at the same time. My other differential diagnosis would be an aortic valve replacement, but this is unlikely as I would expect the click to be just after the S1 or just after the pulse. My other differential diagnosis for mediastinotomy scar would be access to the mediastinum for any thymectomy or pericardectomy or for a heart transplant. So I'd like to manage this patient by first taking history from the patient. I'd like to ask about commitment to and compliance to anticoagulation. I did not appreciate any signs of bruise in this patient. Yeah.
Okay. So, what is the indications of mitral valve replacement?
So mitral valve replacement, indication for mitral valve replacement could be due to valvular degeneration, or it could be due to rheumatic heart disease affecting the mitral valve. It could be due to congenital causes affecting the mitral valve. So it could be due to infective endocarditis as well.
Okay. So how you investigate this patient?
So first of all, after taking history, I'd like to get a set of observations, and I'd like to get a urine dip looking for any signs of hematuria, if any concerns about infective endocarditis. I'd like to start by taking a full blood count. In a full blood count, I'm looking for any signs of infection or any signs of anemia. I'll be looking for any signs. I'd like to get a liver function test and a kidney function test as a baseline, or if any signs of heart congestion or heart failure, I'd expect the liver function to be deranged and kidney function test as a baseline before starting any treatment. I'd like to get clotting, a screen, and INR. I would expect patients with a metallic valve replacement to be on INR, and I need to make sure the patient is meeting the target. For a mitral valve, I would be expecting a target of 2.5 to 3.5 INR. For a mitral valve, I would expect it to be 2 to 3. I'd like as well, if any concerns about infective endocarditis, I'd like to send blood cultures. If any concerns about heart failure, I'd like to send PNP. And I'd like to get an ECG just to have a look to the tracing of the heart. I'd like to get an echocardiogram. In an echocardiogram, I'll be able to confirm the function, assess the function of the heart and the ejection fraction. I'll be able to confirm if there's any valvular disease, affecting the valve, I'll be confirmed if the valve is working or not. And
Okay, how come you will treat this patient?
so it depends on the presentation of the patient. Management should be under the multidisciplinary team approach, and that would involve a cardiologist and a cardiac specialist nurse. It's very important to make sure that the patient's INR is within target, and very important to make sure that there is no interactions with other medications. And management depends on the presentation overall.
Okay. Can you tell me what is the difference between prosthetic and tissue valve?
So valve replacement could be either a metallic or a bioprosthetic. A metallic valve is more durable. A bioprosthetic is less durable. The life expectancy for a bioprosthetic is 12 years. And a metallic valve, we would expect the patient to be lifelong on warfarin. A bioprosthetic, we do not expect the patient to be on long-term anticoagulation. We prefer metallic valves for patients who are younger in age, under the age of 75 in the UK, we consider them for a metallic valve. Patients beyond 75, we would consider them more likely for a tissue valve. It's always about counseling with the patients and understanding their commitment to have warfarin lifelong, which is important for the patients.
Okay. So do you think this valve is functioning good or there's malfunction?
So on examination, I did not appreciate any signs that may suggest a diastolic murmur, and for which I would assume the valve is functioning. But if any, and the patient has had no signs of heart failure, the patient has had no basal crepitations, the patient has had no raised GVB, and the patient has had no pedal edema, which suggests the patient is euvolemic. So with no obvious murmurs to me and no signs of heart failure, I would expect that the valve is functioning. However, if the patient reported that they no longer hear the click, I would be concerned about valve malfunction or dysfunction, and I would like to do an echocardiogram to confirm that.
Okay, thank you.
Okay, one more question. What, in one word, Dr. Inas, when you can say this valve is not functioning well? In one word, after replacement, of course.
If the patient has had a new diastolic murmur. No?
New murmur, no need to mention the timing, okay? Just if you have a murmur, new murmur release or not a new appeared murmur, you can say this is a non-function or dysfunctioning murmur, okay?
Yeah.
Also, you can say absence of the click, but the murmur
Absence
is
of
the
the
most
click, yeah.
important, okay, to mention. Yeah. Okay. Dr. Hani, you can comment now, please.
Okay, actually, she did excellent. Okay.
So I can go and have some water, right?
Okay. So about the examination, I think she didn't miss anything except the dorsal speeds examination. Okay. But she did all the steps of the examination. Okay. I don't know. I didn't remember if she missed the eye examination or she did it. I don't know. About the finding, she presents the finding, decline strength scar and harvesting scar in the leg, and also the apex, which is located in the intercostal space and lateral to the midclavicular line and fasting in nature. Clicky first sound, and she cut the diagnosis with a mitral valve replacement. Okay. About a question, indication of the mitral valve replacement, indication of mitral valve replacement will be mitral regurg or mitral stenosis or mixed mitral valve disease. Okay. I think the target in mitral valve replacement will of INR, the target in INR will be 2.5 to 3.5. Am I right, Dr. Basim?
No, 2 to 3. If it is associated with AF, it will be 2.5 to 3.5. No. Wait. No. Let's recall them because I always start by the aortic valve. So aortic 2 to 3. Yes, you're right.
Yes.
Aortic 2 to 3. Mitral without AF 2.5 to 3.5. With AF 3 to 4. Yes, you're right. So 2.5 to 3.5.
Okay. So about the difference between metallic valves and bioprosthetic valve, as you said, metallic valve with lower rate of valve dysfunction, actually, more durable, maybe last up to 30 years, and require lifelong anticoagulation. So it is preferred in young patients. Bioprosthetic valve, it is less durable, maybe last up to 15 years, and don't require anticoagulation. It is preferable in patients aged 85 years or above. Preferred in patient at risk of bleeding from warfarin or expected poorly complained with warfarin. Okay. About the investigations, she said the investigations actually in a good manner. She justified every investigation, and this is very good. Okay. About the treatment.
The differential. Okay, continue. The treatment.
Okay. About the treatment, also she mentioned the treatment, but in the treatment, it is we best to say pharmacological and non-pharmacological. It is a patient with valve replacement just come for follow-up. So pharmacological, non-pharmacological will be counseling and follow-up, healthy lifestyle, control of underlying disease, dietary counseling, infective endocarditis prophylaxis. Pharmacological will be warfarin, okay, with also counseling and follow-up in warfarin in the clinic, and yellow card. Okay. Surgical if needed.
Is it yellow or red card?
Yellow, I think. For warfarin, I think yellow.
Okay, I will check it quickly. Continue, Dr. Hani.
So this is about the management. In the investigation, we can also add chest X-ray and angiography. Okay. Besides the investigation, which she said. Okay. Some further questions we can put here about the mitral valve replacement. What is a complication? We can ask it about complications of the metallic valves. So it is a metallic valve malfunction or failure, maybe lead to heart failure or sudden death, infective endocarditis, systemic embolization, microangiopathic hemolysis, anticoagulation-related bleeding. These are the complications. If there's a question about the anemia in this patient with mitral valve relapse replacement, what is the causes of anemia? So it is warfarin-related bleeding or microangiopathic hemolysis. Okay. Maybe there's questions about the infective endocarditis. Okay. This is all the question. Maybe more question about the effective endocarditis, but it is not the main subject.
Okay, regarding the differential, so you want to give her satisfaction all, including the differential, but I have comment on the differential. What about the differential diagnosis? She deserves the satisfaction.
What she said about it?
She said, yeah, she said I could give differential of mid-sternum scar, either cardiac transplant or thymectomy, and our case, valve replacement.
Yes, yes.
Said mitral valve replacement, coronary artery bypass surgery, aortic valve
perfect.
replacement.
So you mentioned the cabbage. You mentioned cabbage.
I did. Oh, yeah.
Oh, okay, perfect. Okay, this is what I want to say. Whenever you have harvesting scar, cabbage, you have to put it in the top even before the replacement.
The valve.
The valve, yes. Or it can be simultaneously at the same surgery.
Yeah.
No. It will be valve replacement. You find harvesting scar and you hear click. So you will say it is valve replacement with cabbage.
Perfect. Yes, this is the way. So both of them in the top of my differential. Then the other, as you said, or Dr. Ines said, the thymectomy or cardiac transplant. Or maybe recurrence. Recurrence. You can say recurrence. So he had two mid-sternotomy, and you cannot differentiate between the both. So it can be as a recurrence. So he did, or other valve. So I mean, he opened it twice, not once. There is a case. Sorry, Dr. Hani. There is a case in the past test. There is two scars in the mid-sternotomy. I remember it. So there is two scars. Even the difference 1 millimeter between both scars. But it's very difficult. You have to zoom in to check for the two scars. So means that he had previous surgery of also replacement or valve replacement. Yeah. Now, Dr. Hani.
Sometimes the easiest way to know if it is like double scars,
Okay.
look to how many drain scars.
Perfect.
If you've seen like 8 drain scars, you
This
cannot
is
like
a
have
smart
8.
way. Yeah,
so
this is smart.
they must have, because usually they leave 2 drains to 4
Perfect.
drains per surgery.
Yeah, perfect. Yes, good and smart way. Thank you, Dr. Ina. Yes, Dr. Hani, sorry I interrupted you many times.
No. I just I want to comment about the differential diagnosis of in any case of midline sternum scar.
Okay.
It will be 5 differentials. The first is valve replacement or valve repair. The second will be coronary artery bypass graft cabbage. The third will be heart transplant. The fourth would be congenital heart disease repair. The fifth is thymectomy. This is the 5. It will be if it is mechanical aortic valve or mitral valve or double. Okay, so it is the differential diagnosis. Okay, valve replacement, mitral or aortic or double. Okay. About the mechanical aortic valve will be the second heart sound is clicky metallic. Okay.
There will be a click just after the first heart sound. This is an aortic. So you try to time it with the pulse. If the click is with the pulse, this is a mitral valve. If the click is just after the pulse, it is an aortic. And I got them mixed up until last week. That been explained to me by a cardiologist, actually.
Okay.
Perfect. Yeah, this is the way, and you have to do the timing. Don't say it blindly. If you don't know,
again, you can repeat Dr. Ines again.
Sorry, Dr. Ines. Okay, go ahead, Dr. Ines.
If the click coincides with the pulse, this is mitral. If the click just after the pulse, it is aortic. Or other ways, if the click coincides with S1, this is mitral. If the click just after S1, it's the aortic, because the pulse is usually synchronous with S1.
Okay, Dr. Basim, Dr. Ines, if you cannot confirm it is mitral or aortic or double, we can say the valvular metallic mechanical valve replacement for differential. It is accepted answer.
Both you want to say double?
No, I will mention it is a mechanical valve
Okay,
replacement for
if you
differential.
couldn't distinguish between, okay, better
Yeah.
and safe answer. By the way, your answer is diplomatic one. If you are not sure, this is a first clicky or second clicky. But usually you have to mention the first or second. But if you don't know and you couldn't recognize, is it first or second? Better to say, I heard a clicky sound. I'm not sure, but my differential metallic or replaced valve, metallic replaced valve or replaced metallic valve.
Particularly if the patient has AF. It's very, very
Yeah.
hard to know if it's
Yeah.
aortic or mitral.
Perfect.
So if you feel like AF pulse, do not even waste time in to know if it is this or that. You can just say the patient is in a irregular rhythm. It's very difficult to know if it is mitral or aortic, but this patient has had a mechanical valve replacement. And based on my friend's experience, they cannot really fault you. My friend got a 20 out of 20, and she said that. And she didn't really know if it's mitral or aortic.
Yeah. The other thing I want to say, if you have a murmur, the murmur will give you also more confirmation to your clicky sound. Suppose most of the murmur are systolic one, right? Most of our bases murmur are systolic. So whenever you have a murmur, try to relate the time to the murmur. Is it before the murmur or after the murmur? Whenever you find the murmur comes after the click sound, this is metallic. If the murmur if the click sound after the murmur, this is aortic replacement. Again, if you have a murmur, suppose systolic one, so you will hear the click sound before the murmur. This is mitral metallic valve, or if you hear it after the murmur, this is aortic. Let's simulate it. So you will have tick, tick. This is metallic mitral. If you hear shtick, 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 this is aortic. Okay, this is the easiest way. By the way, if you have another, it's very easy to distinguish both of them by this way. And Dr. Ines also mentioned the heart sound. If the pulse, you feel the pulse before, this is aortic, or you feel the pulse after, this is mitral one.
Can I ask a question?
Yes, sure.
In my previous attempt, I failed my cardiology station, okay? And I've had mid-sternotomy scar, no harvesting scar, and I've had a systolic ejection murmur at the aortic area.
Okay.
And I sold it as this patient likely has had, the patient has no metallic click. I sold it as this patient likely has had a tissue valve replacement, and I appreciated a murmur that could be a flow murmur or could be dysfunction of the valve. And they give me 10 out of 20. And apparently the case was cabbage from Lima and AS murmur.
So no replacement at all.
No replacement at all.
Yeah, that's why. So you couldn't appreciate the harvesting?
What was written, Dr. Ines?
AS
Cabbage
murmur.
and what?
Cabbage from the Lima, from the internal memory artery, I think. I think that stands for it. So cabbage from an
yeah, it's very challenging one. So you don't have harvesting scar.
no harvest. No
yeah,
harvest
that's
scar.
why. Yeah, it's very tricky case. Very difficult one. So you don't have
You mean the cabbage done by internal memory?
Yeah. So you will not have a harvesting scar, and you will not have clicky sound.
No.
So Dr. Ines, guess this is tissue valve because no click sound, but it's not a valve replacement at all. It's harvesting from the internal memory with cabbage, which is a very challenging one. No one can know it.
It was very well. When I reflect on that exam, I just felt if I've mentioned, this midline sternotomy scar could be due to 1, 2, 3, 4, 5, and this murmur could be either AS or if there is valve, it could be a valve problem. Maybe that would have been safer to me. But sometimes you need to make a story of your findings rather than just like give separate differential diagnosis if
Yeah,
you see what I mean.
So they want you to relate and to link the things together, not to just put it as a differential. Supposed to be or could be 1 or 2 and 3. They want you to give justification of your answer and your differential, which is sensible differential. But I think you mentioned also the cabbage. What if you didn't
I didn't.
mention the cabbage?
I didn't in my
didn't?
exams. No,
Yeah.
I didn't. No.
That's why. Yeah, that's why they minus you to the half, which is fair mark, by the way. Really, it's a fair mark to have the half mark if you couldn't mention the differential. Okay. Of course, if you mention the differential, maybe they will give you up to 15 or at least 14. But since you didn't mention it and you put good management plan and investigation, at least they give you the half mark. So borderline in every skill. Okay. It's very challenging case, by the way, to have a scar with no click hard sound means that you have a cabbage which is to the internal memory, from the internal as harvesting from the body itself. So no harvesting. So they will connect the coronary to the internal memory directly without harvesting. Okay, and sometimes they do it. I don't know the situation, but need the cardiology opinion to tell us about it. Maybe related to certain artery. So there is specific artery. If it's stenotic or clotted, maybe I'm not sure. Maybe lead. I will confirm this from cardiology. When exactly they do this, or someone can search on the Google now. When they do the internal memory as a cabbage and secure to the artery. Which artery exactly from the heart? Let's see if someone can share it or
Can I
search
ask
about
another
it.
question
Yeah,
until we
sure,
get the
Dr.
answer?
Yeah.
What are the indications of prophylaxis in these metallic valve replacements? Is it like automatic for all the time,
No,
or
not
prior to
automatic.
procedures?
There is 5 or 4 indication of prophylaxis for you mean infective endocarditis, right? Prophylaxis of infective endocarditis.
No, I mean for metallic valve replacement, because the doctor I'm practicing with, he mentioned in the management about the prophylaxis.
Yes, prophylaxis, antibiotics prophylaxis.
When?
When?
the time?
Yes. No, not all the time. There is 4 indication, clear 4 you have to memorize it by heart. First of all, if you have previous infective endocarditis. Okay. Second, if you have cardiac transplant or correction or congenital heart disease. And the fourth is, so let's recall them because I didn't say them before since long time. The previous infective endocarditis, cardiac transplant, partially or totally corrected congenital heart disease, and one more. Someone can recall it with me. Infective endocarditis, cardiac transplant, corrected congenital heart disease. But it's not mandatory as before to give it in any surgery. Okay. Before they are giving or they were giving antibiotics for prophylaxis with every surgery, like dental surgery. Nowadays, it's not mandatory unless the patient is having these 3 or 4 indication. Okay. Clear now, Dr. Inas?
Yeah, thank you very much.
Okay, Dr. Hani, it's okay. Sorry, we are lengthy today. You can leave. I will send it to the WhatsApp group after the meeting. So the indication of renal of prophylaxis antibiotics, plus the indication of internal memory reconstruction for cabbage. Anyone has other question? The card, yes, I revised the card. It's yellow card for the warfarin, exactly, as Dr. Hani mentioned. Infected procedure. Dr. Khalid mentioned infected procedure. What do you mean by infected procedure? Dr. Asila. Yes, prosthetic valve, including these are the high risk of cardiac condition requiring prophylaxis. Okay, perfect. Prosthetic valve, including transcatheter TAVI, surgical valve, prosthetic valve, aneuplasty rings, previous infective, this is what I mentioned. So previous infective endocarditis, congenital heart disease, either corrected partially or totally, and cardiac transplant. So I mentioned 3 of them. The fourth, prosthetic valve. Prosthetic valve, including in transcatheter TAVR, they are having high risk for infective endocarditis and they need prophylaxis. And the procedure requiring prophylaxis, the dental procedure, as I said. So dental procedure, they are giving this medication if the patient is having the fourth condition I mentioned. Okay, but not every procedure. If you have major procedure, also I think they have. If you have culture with bovis, it's streptococcus bovis, and you are going to do colonoscopy, also this is an indication to do the to give the antibiotic prophylaxis antibiotics. Okay. Everyone should know about the infective endocarditis before the exam. Most of the examiner, they will take you to this topic. You have to be ready when to start, what are the criteria, what is the major and Duke criteria, major and minor, when to start the medication. Okay, and the target INR, of course, you have to know them. All this stuff should be known. Like dental, yes, Dr. Khalid. Thank you. Yes, so infective procedure like dental, yes, as I said. Thank you, Dr. Khalid. Dr. Awake, very good session. Thanks, everyone. Will you continue the practice session even after March diet? I am aiming June, July diets. Thanks. It's since no stop. We don't have a stop, fortunately, unless there is some vacation like Eid. We can take 1 day or 1 week off in the summer also. So it's a continuous session every day, hopefully forever. Young. Doctor, yes, very nice session and good presentation. Thanks, guys. You are amazing. Best of luck. Thank you too. Thank you, all of you. Happy Ramadan for all of you. Okay. I think this is the time before end the session. Anyone has a question or comment? If no, we can end the session. Thank you, everyone. See you tomorrow with the long clinical consultation day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you too.
Thank you.